obstructive sleep apnea and diabetes a continuum, as it is said that about 83% of type 2 diabetes patients suffer from unrecognized sleep apnea, and increasing severity of OSA is associated with worsening of glucose control. So to know more about it, I welcome on stage our speaker for today, Dr. Satish Gupta, who is the senior most consultant in medicine and critical care medicine attached to Narayana, and with him, I also welcome chairpersons Dr. Rahul Chatterjee and Dr. T.K. Pal. Both of them are renowned chest physicians. Speakers and chairpersons, I welcome you on stage.
Welcome today morning. This session is sleep apnea. Yes, sleep apnea. Obstructive sleep apnea. Satish Gupta is a well-known chest specialist in Narayana and also medical specialist and critical care. With this introduction, please start your deliberations.
Thank you, sir. Namaskar. I'm glad that nobody's sleepy yet, but I'm sure as the day goes on, we'll find out how many of you have OSA. আপনারা হয়তো ভাবছেন যে ডায়াবেটিসে তো নেফ্রোপ্যাথি হয়, ophthalmopathy হয়, neuropathy হয়. What is a chest physician doing here? So over the next 20 minutes, I'm going to talk initially a little bit about sleep apnea, and then we will explore what is the link between sleep apnea and Howrah Diabetes Society or diabetes. So what is obstructive sleep apnea? See, when we go to sleep, our muscle tone drops, and our oropharynx and nasopharynx are essentially musculofascial tubes. And when we breathe in, then this tube tends to collapse. Those of you who are my age will remember we used to have paper straws, and when we drank our Thumbs Up or Coca-Cola or whatever it is, when the straw became soggy, when we tried to sip in, the straw would collapse. This is exactly what happens in our oropharynx and nasopharynx when we breathe in. This is especially true if you're big and if you have a thick neck or a collar size more than 17. And what we can see there is the patient's airway in a normal person and the narrowed airway in a slightly bulky person. The airway keeps collapsing, and as it collapses, the airflow to the lungs is limited, the saturation in the blood drops, the brain feels hypoxic, and it wakes up, what we call arousal. Now, the patient doesn't necessarily sit up and open his eyes, but the brain wakes up, the muscle tone is restored, and the airway is open again, and the patient goes back to sleep again. But this cycle keeps repeating throughout the night. As we can see there, if you have a 90% reduction in flow lasting 10 seconds, that is an apnea. If you have less than 90% reduction, but more than 30%, which causes a significant desaturation of about 3%, but it has to last 10 seconds, that is hypopnea. And this is the measure that we use to quantify the obstructive sleep apnea, the apnea-hypopnea index. We club the number of apneas and hypopneas overnight, divided by the number of hours we are sleeping, and calculate the per hour figure. Now, anything more than 15 is significant, and things more than 30 is serious. This shows what happens during the night. As the flow flattens, the saturation dips. As the saturation dips, the third graph shows that our respiratory muscles work more, so there is excessive respiratory muscle activity, and there is a sympathetic surge and increase in blood pressure. I was hoping that Dr. Bismay Kumar would mention obstructive sleep apnea as an important cause of resistant hypertension. If we look at the graph on the top, that is our normal sleep cycle. From wakefulness, we go to stage 1, 2, 3, and the non-REM or the slow wave sleep, and we keep cycling throughout the night, but we don't really wake up. The graph doesn't go right up till the morning, so we wake up refreshed. But in a patient with obstructive sleep apnea, what we see is that the patient, before even he can reach the non-REM or slow wave sleep, the airway is closed, there is hypoxia, the brain wakes up, and the person goes to wakefulness. And this keeps happening right through the night. And when the person wakes up in the morning, he has a headache, he doesn't feel refreshed, he feels as if he's not had a good night's sleep, and as a consequence has excessive daytime sleepiness. Now, this excessive daytime somnolence is perhaps the most important feature of obstructive sleep apnea, and it is this that led to the identification of this entity in the big lorry drivers in Australia who were falling asleep on their truck wheels and causing accidents. But over the years, we have realized that this is more serious than that, and it has cardiovascular consequences, neurological consequences, and metabolic consequences. You can quantify this daytime sleepiness using one of these scores. I personally like the Epworth score, but you can use any one of them. And once you think that your patient has sleep apnea and has a high excessive daytime somnolence score, you have to send them for a sleep study. Now, you needn't send them for a full polysomnography. A full polysomnography means you have to send a patient to a sleep lab. It costs an arm and a leg. As far as we are concerned, for obstructive sleep apnea, and if you're not concerned about the complex neurological sleep disorders, you can just do a basic 4-channel study with an ECG or just a heart rate monitor, which can be done by the oximeter that you have got. You can measure nasal flow and thoracoabdominal movements. And this can be done with a portable machine, which your technician can take to the patient's home. It is convenient, it is easy, it can happen at the patient's home, and it is cheap. And it has been validated to be not inferior to a full polysomnography as far as obstructive sleep apnea is concerned. Once you have made the diagnosis of obstructive sleep apnea, now, there will be a small number of patients who might require some sort of surgical intervention or dental or oral appliances, but the mainstay of therapy is CPAP. Of course, you would advise them to modify their diet and try to lose weight and stop taking sedatives or alcohol in the evening. Now, you might think that this is a white man's problem. But this is a study from Singapore. Now, Singapore, as we know, has a mix of Indians, Malaysians, and Chinese. And they have a fairly high prevalence of sleep apnea. These are 30% of Singapore population has an apnea-hypopnea index of over 15. Significant sleep apnea syndrome in 18%. There are split figures to show the different 3 different communities as well. So it is very much our problem too. So all that is good, but how does that relate to diabetes? Now, over the next few slides, we're going to first explore the link, the prevalence and incidence of diabetes in patients of OSA and vice versa. Then we'll see what is the pathophysiological link and see if treating OSA has any effect on diabetes. Now, this is a study. It looked at prevalence of sleep disorder breathing, essentially OSA, in patients with type 2 diabetes. About 300 patients, and nearly 50% of the males had significant obstructive sleep apnea. If you add obesity to diabetes, then more than half. I mean, if you look at the graph here, nearly 75% of patients have some degree of sleep apnea, and more than half have significant sleep apnea. This is a nice, simple, but very interesting study. What it did was, it was looking at the prevalence, incidence of development of diabetes over a period of 10 years in about 70,000 people. And all that they did was ask them that, do you snore? And people who said that they regularly snored and they were overweight had a much higher risk of developing diabetes. Here, the snoring and the weight is a surrogate marker of obstructive sleep apnea. They didn't do any sleep studies or anything. This is a very sort of popular, commonly quoted study, which looked at nearly 1,500 patients over a period of 4 years who had a good baseline evaluation, and they were followed up over a 4-year period for development of diabetes. And we can see that the odds ratio of developing diabetes is 4 times in patients who have an AHI of more than 15. Okay, this is a basic science study. This is looking at insulin resistance in patients with obstructive sleep apnea. They do this by this HOMA technique, which the endocrinologist perhaps could tell you more about. And if you look that the insulin resistance is highest in patients who have AHI of more than 20 or even in AHI of more than 40 at the right hand side of the slide. This is a group of patients who have type 2 diabetes and OSA. And if you look, that the patients with the worst OSA have the worst HbA1c. So there is perhaps a causal relationship there. This is a very interesting study. This is, there are 3 groups of people. If you look at the graph on the top, this is doing a GTT on a normal group of people, which is the blue line, in patients who are obese but do not have obstructive sleep apnea, which is the red line, and the top black line is patients who are obese and have obstructive sleep apnea. So what we can see is that obesity causes your GT to get worse, but OSA has an effect over and above the obesity. The same thing is reflected in insulin levels here, which implies insulin resistance, which is the highest in patients with obesity and obstructive sleep apnea. This is 2 groups of people. Normal, the red line, and people with OSA, followed up over 5 years. Again, it separates out, indicating there is a higher chance of developing diabetes if you have OSA. So what's the link? This is a nice, colorful slide. And if we look, sleep disordered breathing causes 2 main things. It fragments your sleep and it causes intermittent hypoxia. And this drives the hypothalamic pituitary axis, and the sympathetic system causes excess of catecholamines and cortisol. And the hypoxia also causes release of inflammatory mediators throughout the body. And all this causes insulin resistance, glucose intolerance, and type 2 diabetes mellitus. So does treating obstructive sleep apnea make a difference to patients with diabetes? Here we have 2 groups of patients. The top red line is a group of OSA patients who are on CPAP. The bottom line is OSA patients who are not on CPAP. So we find that the chance of developing diabetes is higher in patients who have obstructive sleep apnea who are not treated. This is an interesting study. Basically, this is looking at people with obstructive sleep apnea and what happens to their insulin sensitivity as we put them on CPAP. And you can see in as short as 48 hours, there is improvement in insulin sensitivity, and in 3 months it is better still. And this is the same thing, 3 months and 3 years. There is significant improvement in insulin sensitivity when you treat your OSA patients with CPAP. It's a very elegant study. Only 25 patients. These are patients who have diabetes and OSA, and they had a baseline glucose profile and HbA1c. They were then put on 3 months of CPAP therapy, and the whole thing was repeated. And if you look, the red dots, that is their baseline glucose profile. This is done by continuous glucose monitoring. And if you look at the yellow dots, that is after 3 months of CPAP. And there is a significant improvement in the glucose profile throughout the day when you treat your OSA patients with CPAP. The same thing is reflected in the HbA1c. There is almost 0.5% or more than 0.5% drop in your HbA1c when you treat your OSA with CPAP. And this is more in patients whose baseline HbA1cs are more than 7. So your worst diabetes group and your worst hypertensive groups, they do better when you treat them if they have OSA. And you treat diabetes because you want to improve their outcomes, which is primarily cardiovascular outcomes. It's the same. The prevalence of sleep apnea in all these conditions is so high that you really ought to look at all your patients with diabetes and obesity, and you should think, does this patient have obstructive sleep apnea? And if you think so, then you should you can refer them to me, or you can at least do this home sleep study. And that is what we do when we treating or looking at a patient with obstructive sleep apnea. We look at their other risk factors. That way, we work at improving outcomes for our patient. Thank you. I think I'm a little bit before time, so happy to take any questions. Price question.
Sir, I would request for the price question.
So what's the most important measure of obstructive sleep apnea? AHI. Who was that?
Who
I heard
answered
AHI.
kindly?
Who was the...
Okay.
Yeah. Good.
Who answered?
Prize goes to you.
You can't give the repeat prize to the same person.
Actually, he already answered a question
Oh, he's
in
too
the
good.
previous presentation.
You have to share it. Somebody new.
New person?
Not a question?
Now you know the
No, no.
answer AHI. You might as well tell me what is the full form of it. Anyone.
Okay.
एवं बोला है ना। तो हाथ तोलो और तुम जाओ।
One person, kindly raise your hand, sir, please.
I had a question, okay. So what is the level of AHI at which we say you have significant obstructive sleep apnea?
Greater than 30.
Sorry, I couldn't hear that.
Greater than 30 severe.
Sorry?
Greater than 30 severe.
Okay, I use the word significant. if you
15 to
notice.
30.
15, yeah. I think I would go for 15 as significant problem. 30 is severe OSA. So yes, I think we'll divide it between these two guys, I think.
Premanjan Bhattacharya from Narayana Super Speciality Hospital.
Thank you, sir. We have a small token for you.
Okay. Unless there is a
I
question,
request the
or
chairpersons
unless,
kindly, sir,
any comments from the chair?
for your words.
Sir, I had a question.
Yes.
I am Dr. Sushil Das,
Yes.
practicing in Sipur area, general physician. Last week, I get a patient of a 12-year adolescent having cough for last 3 months. And interestingly, patient is quite obese according to his height. His height is around 4'3", but his body weight is around 78. His mother is also a patient of hypothyroidism. I advise some routine test along with thyroid. Her mother told that he is severely snoring.
Yeah.
Whether the chance of any adolescent age group ASO developing or not.
Yeah, I mean, this patient needs a full evaluation. What you said that the age was
Age is 12 years
12.
old.
I mean, I think this is not just an isolated, pure sleep apnea sort of problem. I wonder if he might have a metabolic syndrome of some sort. We definitely need to do some sort of a weight management program, which might involve diet, exercise, or even some surgical intervention. So you really need to explore it a bit more. I think from what you're describing, this patient almost certainly has an element of obstructive sleep apnea. If he's big, then he might have some Pickwickian problem, as in central sleep apnea element as well. So you would have to do a sleep study in addition to all your other evaluation, but that would constitute only a part of the management of the whole child. So I think he should come to NSH on the day when Sanjay and myself are doing parallel clinics in the two
Interestingly, his sugar level is quite high.
Yeah,
Fasting is around 138 and PP is 208.
Yes.
And HbA1c is quite higher than 7.5.
Yes,
It
yes.
was 8.2.
Yeah, so he's got the full-blown metabolic syndrome.
Metabolic
So
syndrome,
we
yeah.
need to make a diagnosis whether he's got some sort of a genetic diabetes, obesity syndrome, whether he might have other endocrinopathies, and of course we can delineate his obstructive and central apneas and give him appropriate treatment. If he has significant central apneas, then he might require a BiPAP, an NIV type of equipment. Then, but I think we need to explore all the other less invasive measures before we launch, since he's only 12.
In my last visit, day before yesterday, I referred the patient to you also
Oh,
to consult. Yeah. for
okay.
Thank you.
So we'll try and do our best for him.
Thank
you.
Dr. Gupta, I am Dr. Mujumdar. Thank you for your precise presentation, very beautiful presentation. Now, only one or two comments. Now, it's such a common thing in association with metabolic syndrome. Sometimes some connotation has been given, like syndrome Z, when metabolic syndrome is added to this obstructive sleep apnea. So it's a spectrum disorder along with metabolic syndrome. Only one point I want to mention, that sometimes reduction of body weight, obesity management, sometimes these patients may get improvement. So that is one comment. And second comment is that these patients are notorious for atrial fibrillation, particularly cardiovascular problem, and sudden cardiac death may has been recorded. So I think some precautions against atrial fibrillation, arrhythmias actually, coming to the scoring system, these patients may require some anti-fibrillatory measures also.
Thank you.
Thank you.
Thank you very much, Dr. Gupta. I'd like to continue the question put by Dr. Majumdar, that these patients, that is, this type of patient that is sleep apnea patient, they sometimes suffer a sudden death. Maybe is there any relation of cardiomyopathy with some arrhythmia, like ventricular arrhythmia is possible in the
Yeah, actually, because of the time constraint, I did not get into some of the other things, but there is excellent relationships with OSA and hypertension, and this is the slide I had, that there is a substantial evidence linking OSA to cardiac arrhythmia, especially atrial fibrillation. 17-fold increase odds of an arrhythmia. I remember when we were in Leeds, I had a patient who came in. There you could quickly get an ambulance and get your CPR and survive, who had multiple hospital admissions with VFib. And he had all the EPS studies and everything. And at the end, he was found to have obstructive sleep apnea, and he needed a CPAP machine, and his arrhythmias disappeared. But I mean, a lot of these patients, as Dr. Majumdar said, they have a lot of things going on together, and they need a multimodal approach. But quite often, like I think it's true of me and it's true of most of you, that we focus on pharmacology rather than maybe the exercise, music, and the sleep. So.
Good afternoon, sir. Myself, Dr. Sakar. Sir, actually, how effective is weight reduction with respect to OSAs? Basically, I am practicing in a place where patients do not have too much of money to spend on the doctors. So how effective is weight loss for that point of view? Like how much it is effective? Like how much weight loss, like if the patient is obese more than, the BMI is more than 30. So what can we expect? Like if the patient generally, if I explain the patient that you have to reduce the weight in a particular manner and something, I give them the diet plan, workout plan and everything. And if they reduce the weight, how effective is, like I can expect how much improvement in the patient with respect to diabetes or metabolic syndrome overall?
What I'd like to say is, see, weight reduction is not easy. And what you would find is when you brought in not affording, etc. What you will find is the people who are more affording can look after their health, they can eat better, they can exercise, go to a gym, they're more aware, and they are perhaps less overweight. And it's the people who can't afford the right sort of food, have to work 12 hours to make ends meet, and they are overweight. If you can manage to lose, say, about my average OSA patient will be 90 plus 100 kilos, and if they can manage to lose 15 kilos weight, their OSA might disappear. So you can do a repeat study. I have a patient who is a colleague, he's a doctor, and he is a radiologist, and he used to do ultrasounds, and he came to me once, and then when we treated him, he was 115 kilos, he brought it down to 95. He came and he said that, thank you very much, you have improved my practice. And I said, how? He says that aage ami clinic ultrasound korte jetam ghumiye portam, the polyclinical lokera amake case dito na. Ekhon ami jege thaki, my somnolence is gone, and he was able to come off the machine. The problem is, you might be able to lose weight, motivation and all that, but to keep that weight there is a tough call. I think most physicians, Dr. Sanjay, you'd agree with me. Or abar ute boshe. BA hobe, tar age, loke gym team giye, people manage to lose a lot of weight. It is surprising, but it is hard to keep it up. So yes, if you manage to lose weight, fine. But if you have to go for anything more than diet and exercise, that's going to cost you more than the machine. So.
Thank you, sir.
So I have a question. So it is common that OSA is common in obese patients, but in some studies it has been seen that even in non-obese patients with BMI below 30 or maybe 28.
Yes.
So in that case, weight loss is not the option we have. So what options do we have apart from that? Then anatomical structures are almost normal in those patients.
Yeah.
So what options do we have in that treatment?
You're absolutely right. I mean, this is the bulk of the patients. I'm punning on the word bulk, but there are patients with craniofacial abnormalities who might need some specific surgical intervention, but there are normal adults who are not overweight who have sleep apnea. You have to have a high index of suspicion, and your daytime somnolence is the key, and you would treat them with CPAP.
CPAP is an option.
Yeah.
Sir, I have a trivial question. Though it is something away from your lecture. Sir, sometimes we see patients with respiratory problem, and we usually all use the pulse oximeter in the chamber. So can you give us any impetus? What is the skeptical marking of the oxygen saturation? From seeing that, we can refer the patient for further interference. What is the actual level of it?
It's a very loaded question. I don't want to get the answer wrong and convey a message which might give you a false sense of security. But rather than a resting oximeter, if you made your patient walk in the clinic a few times, and if they drop their saturation, that calls for further evaluation and you might want to refer. So এসেছে ক্লিনিকে বসে আছে আধ ঘন্টা আপনাকে দেখার আগে, তারপরে ঘরে ঢুকে আপনি দেখলেন যে স্যাচুরেশন ঠিক আছে, তাতে খুব বেশি কিন্তু সুবিধে হলো না। ইট ইজ লাইক আ রেস্টিং ইসিজি ফর দি কার্ডিওলজিস্ট। আপনাকে ওকে যদি একটা সিঁড়ি থাকে দুবার নামিয়ে উঠিয়ে ক্লিনিকে বসি, তারপরে যদি দেখেন যে স্যাচুরেশন ইজ নট নর্মাল, when I say not normal means it is less than 97%. Unless he is a known COPD, সেটা একটা আলাদা জিনিস, then you would want to refer that patient for evaluation as to what is the cause for this patient's exertional hypoxia, which indicates that there is a problem in the lungs.
পেশেন্টের সার্কোইডোসিস হয়েছে, কিন্তু লাং ইনভলভমেন্ট ইজ নট সো প্রোনাউন্সড অন দ্য respiratory analysis, it is not so prominent. But the patient is suffering from obstructive sleep apnea. The patient is little obese. She is not hypertensive, she is not diabetes, she is little suffering from thyroid. So this patient is requiring BiPAP machines. So do you think that sarcoidosis sometimes produces some sort of pathology in the lungs that is the culprit of this problem?
No, that would not be supported by the literature. Sarcoid can affect the lungs per se. It can also cause mediastinal lymphadenopathy, which can cause its own problems. But I would not ascribe obstructive sleep apnea to sarcoid.
Because the patient is, when in the morning he is feeling nothing, but from the evening time when he is going to the bed, he feels sleepy and pulse oximeter is seen, thus its oxygen saturation is going down.
So you see, obstructive sleep apnea, daytime pulse oximeter saturation going down doesn't quite fit. What you have is nocturnal obstruction and drop in saturation at that time. So it is not quite fitting with a clean-cut diagnosis of obstructive sleep apnea. And sarcoid is an important cause of interstitial lung disease. It is a well-known cause of hypoxia, but then there should not be a difference between the morning saturation and the evening saturation. I wonder if there's something else going on.
So I think we should close the session now. Thank you, Dr. Gupta, for an excellent talk and very well fielded questions.
Thank you. Thank you all.